spot.
Okay, so so we should start out with kind of a definition of terms, because people talk about heart failure all the time, and I think we mean different things sometimes, especially outside of cardiology. The concept of what heart failure actually is maybe not exactly what we understand it to be, because we have different terms like we have CHF. In recent years we've kind of dropped the C on this term, and I'll explain why in just a minute. But so heart failure is going to be a little bit different from cardiomyopathy, right? They're not identical terms. And how do they differ? So cardiomyopathy talks about an abnormality of the heart muscle, and there are several different kinds. But this is talking specifically about heart muscle pathology, not necessarily a clinical syndrome. The clinical syndrome is in heart failure. So this leads to heart failure. But you can have all kinds of types of cardiomyopathies. The major categories would be dilated, ischemic, hypertrophic, maybe running out of juice here, infiltrative, okay, we switch. Talk's over. And some of these are not perfectly mutually exclusive. Some of them they overlap. But you'll have heritable cardiomyopathies, and that's going to be that'll lead to sometimes infiltrative, hypertrophics, and dilateds. You can have a viral, post-viral syndrome, which sometimes is the diagnosis of exclusion. When we've decided that it's none of the other things, we say, well, it must be viral, which isn't always the case. Honestly, sometimes it's that we've missed something else, including the heritable cardiomyopathies that we very seldom test for. You can have valvular heart disease that'll lead to a dysfunction of the heart muscle. It wasn't really the fault of the myocardium, but it was the valvular abnormality, either aortic stenosis or mitral regurgitation, aortic regurgitation, usually that are the ones that cause this. You can have congenital heart disease. And then you can have, on the right side, you can have the phenomenon of corpulence. So these are kind of the major categories. Again, the dilated type, it depends on what stage of the disease you've caught the patient, because honestly, most of these, the final common pathway is that the patient ultimately, if they live long enough, begin to dilate. Even if they started as a hypertroph or as something else, eventually, again, if we're able to kind of keep them in shape, many of them will end up in a dilated state. The ischemics, because these are the limited coronary blood flow to the myocardium, leading to either just a dysfunction, a temporary dysfunction, that if we relieve it with coronary intervention, that gets better, or potentially myocardial infarction that will lead to a permanent dysfunction of the heart. Hypertrophs are going to be, oh, by the way, there's hypertensive in here too. Hypertensive. Hypertrophs are typically, so we have to kind of separate the concepts of, well, it's thick. Well, is it thick because they have hypertensive heart disease, or are they thick because they have a genetic condition that's predisposed to the malformation of the myocardial fibers? So when the heart muscle is very thick in hypertension, that actually all the fibers are going in the right direction. They're all set. The tissue is set up correctly. It's just become too thick. It's an adaptive response to way too much blood pressure over the years. years. In the case of a hypertrophic cardiomyopathy, a genetic condition, you actually have malformation in the endocardium, the mesocardium, and the epicardium they're supposed to be aligned in a certain direction. And as it turns out, they get misfigured and the fibers are going in all different directions. It's a thick muscle, but it's dysfunctional muscle. It's not pulling in the same direction in an effective way.
So do they have to do like a biopsy to figure out, if they have?
You can. So biopsies can sometimes tell us about this more commonly because we do biopsies so infrequently now.
Mm-hmm.
One, because it does carry some degree of risk, and two, because there are fewer and fewer people who do it, who know how to do it. Right? And the instruments and such are becoming less common. The other way we do it is by checking a family history, because it's not usually just a proband. You haven't just caught usually the first one. There's a history of it. Maybe it was undiagnosed before, but if you dig in and eventually find out that, well, yeah, mom's ankles were swelling, grandmother's ankles were swelling, and you can kind of go back and see how there might have been family history. But that certainly is something that's a relatively under-recognized phenomenon. Infiltrative cardiomyopathy can become hypertrophic, can become thick, but it's not because the myofibrils are misformed. It's because you're putting abnormal proteins and other materials into the myocardium, which makes them thick and dysfunctional. So what kind of things, what examples can you think of?
Sarcoid.
Yeah, cardiac sarcoid. What else? Other ones like
Oh, amyloidosis. Give us a clue. It starts with sounds like.
so amyloidosis, which is the more common of the infiltrative cardiomyopathies. And overall, these aren't super common, but they're way underdiagnosed compared to the prevalence in the community. And you have now I'm blanking on the last one. There are others too, but hemochromatosis.
Oh, yeah.
So we're putting iron into the heart muscle, and that doesn't work out well for the patient. So heritable cardiomyopathies are going to be, again, this is a broad category and it overlaps with some of what I've already talked about. And these are genetic conditions that are passed down from one family member to another. You really, when you have heart failure, when you have a heart failure patient in front of you, it's really important to do at least a two-generation family history to find out just what's going on, because you can begin to get an idea of an inherited condition. When you start hearing about all these things, maybe the patient hasn't even thought about this before. But if you dig a little bit, sometimes you'll start to hear about a pattern. And if it turns out it's all males in the family, if it's all on one side, if it's, or if it's happening in a certain heritable pattern, there's Mendelian genetics that can help you to figure out if you have potentially an inheritance pattern of autosomal dominant, autosomal recessive, or X-linked type of inheritance pattern. This is not the genetics course to go over all this, but I can tell you in general, most heritable cardiomyopathies of structural proteins, most of them that we're going to encounter are going to be autosomal dominant in their inheritance pattern, which means that you get 50% passage from one generation to another. Right? So if it happens on a autosomal chromosome, meaning that it's a non-sex chromosome, it's passed with 50% prevalence from one person to another, because they're going to be passing one of their autosomal copies. The other parent is going to pass the other one. So then you have a 50-50 chance of the two copies of the affected patient to affect the patient. So anyway, that's the most common way to get a cardiomyopathy. The autosomal recessives are more of the enzyme kind of cardiomyopathies. So these are going to be the ones where you have to have 2 hits in order to affect the patient. So if you had 2 patients, and again, this is why it's so much rarer, if you have an enzyme abnormality and say they met in the waiting room of a heritable cardiomyopathy clinic, not a good place to go dating. But if that happened, you might have more common incidents of 2 affected people, each with a single, copy, or maybe they both have double copies. If they both had double copies, their chance would be 100% of transmission. Otherwise, it gets much rarer in the autosomal type. X-linked, you're going to see just usually males are the ones that are affected most prevalently. Okay. Oh, that doesn't clean very well, does it? Yuck. Okay, so virals. Why do patients develop a cardiomyopathy as a result of a virus? Is it because the virus is attacking the muscle? Is it a really bad adenovirus? It's just virulent against the myocardium?
Is it just a response to the increased metabolic demand of the viral illness?
No. It's actually, that's a good thought, but it's actually, the virus carries a kind of a fingerprint, and the immune system gets revved up, and it recognizes the fingerprint, and usually in most people, it'll kill the virus, and that's you essentially grab the fingerprint from one set of beta cells, and then it sends out a lot of other immune cells, and then ultimately you come back and kill all the other viruses anywhere else in the body because you've recognized that one virus is foreign, and so that's how you can replicate and duplicate your immunity for a particular pathogen. Well, in the case of a viral cardiomyopathy, for some patients, the fingerprint of the virus looks very similar to the fingerprint of the myocardium. So you actually set up an autoimmune response so that you then recognize the myocardium as foreign, and then the immune system beats up the heart.
For someone with other autoimmune diseases, is it more common for them to get this?
If you have one autoimmune condition, your likelihood of having others is much, much higher than the average. So that's probably a fair statement. I mentioned the other, and by the way, adenovirus is the most common by far. There are others, but they're much less likely. Most of the respiratory viruses are the ones that are going to cause this, and most patients might even feel this as just a URI, or maybe it's a pneumonia, viral pneumonia, and then they resolve that, and they might not have any residual symptoms or indications that they've had damage to the myocardium for weeks, months, or years.
Oh, wow.
Now, they can, sometimes we'll hear about a more precipitous case that in, a few weeks that they begin to decompensate because all the short-term things that the heart's doing, they kind of run out of gas, and their potential to compensate for the low output is overcome, and then they begin to swell the fluid, and that's usually when they present. Or it could be much, much later. They could have a hit on the myocardium that then takes years to manifest. They're well compensated until they develop another illness.
Oh, yeah.
Or they just become older, or something else happens, a stress of some sort, and then they decompensate what was previously a compensated state of cardiomyopathy without heart failure. Congenital, well, we talked about valvular heart diseases a bit, and these are the more common things we deal with all the time in structural and otherwise. So congenital is going to be based on a similar concept. There's no particular problem with the myocardium, but because we have pressure overload or overwork of the heart muscle from blood shunting, usually this causes the congenital patient to develop heart failure. And again, this is a whole talk by itself. This dives pretty deep. The population is relatively small, but it's out there. And usually when we find these patients, they get referred to either a specific heart failure clinic or an adult congenital heart failure clinic. Hopefully they've been recognized as children, sometimes operated, and there's a smooth transition from PD cardiology over to adult congenital cardiology. But again, those clinics are only in the academic centers. If they're not near an academic center, they end up in a maybe a heart failure clinic, or maybe just in a general cardiology clinic, and it's tough. It's very difficult for those patients to live out away from subspecialty healthcare, but they do. So this gets complex into things like a tetralogy of flow that's either corrected or uncorrected. You can have a congenital correction of a TGA, transition
So
or
even,
transposition agreement.
even after it's corrected, they still have a chance of getting pregnant.
Yeah, so, something like a tetralogy. What's happening in that physiology is pulmonic stenosis. Sometimes you'll get a patch that'll expand the pulmonary outflow tract. You'll get sometimes a new pulmonary valve. Sometimes they'll take the aortic valve and move it over. There's a lot of different ways to fix this.
Mm-hmm.
You also have a VSD and all kinds of things that need to be corrected. Usually it's that the pulmonary regurgitation gets terrible and you bomb the right side again, or the pulmonic stenosis comes back, or there's a number of things that can happen with that. You can have other relatively unrecognized conditions of ASDs and VSDs that might be fine for a while. So the ASD usually is fine. You sort of get minimal or maybe bidirectional flow until a time when the patient starts to shunt more over to the right side. This is a non-cyanotic congenital heart condition, so that you get high oxygen blood from the left atrium that will go over to the right atrium, and then it gets circulated again. The right side of the heart just circulated this blood, went through the pulmonary circuit back down, and now it has to do that plus what's coming back from the body. So what you end up doing is ultimately overloading the right side, and you'll get dilatation, you'll get hypertrophy, and you'll get systolic dysfunction, ultimately leading to pulmonary hypertension. And when you have pulmonary hypertension that keeps going up, that ultimately it can rise and say, so if your systemic pressures are then equal, and usually the patient will get an illness again that pushes them over the edge, or maybe they just gradually come to this condition, they'll eventually reverse the flow. This is an Eisenmenger syndrome, where the patient's pulmonary artery pressure exceeds the systemic pressures. And again, not usually in the ASD case. This can happen. Usually you get a more garden variety heart failure. It's more in the ventricular septal defect, where you'll get an Eisenmenger syndrome, where the PA pressures exceed the systemic pressures, and then you get cyanotic heart disease of low oxygen blood flowing before the pulmonary circuit, right over to the systemic circulation, and then the patient's subcyanotic and hypoxemic all the time. And lots of different examples of this, and these can get quite exotic, and single ventricles and all sorts of things, pulmonary atresias, and sometimes the ways that we surgically correct these conditions can be really creative. Sometimes they're staged conditions where we have to operate on them and then operate on them again and then again, and then as they grow or as the physiology changes, we have to adapt to their circulatory needs. That's Eisenmenger's. Cor pulmonale is a bit of what I was talking about, or it's the similar response, but due to a different reason. In the case of cor pulmonale, we have so you have the lungs here, and so this is supposed to be the PA, and what happens is, due to an insult to the lungs, you can end up developing cor pulmonale. And a number of reasons, but the common link is that you have difficulty, high resistance in the pulmonary circuit to move blood across the lungs over to the right, to the left side of the heart. When that happens, and that can happen because of things like chronic PE. You can get primary lung disease. Most commonly this is COPD. But you can get other things, pulmonary fibrosis, and anything that's going to cause, even tuberculosis. And if we've had to resect part of the lung, and then it's harder to get blood across the pulmonary circuit that way. Anyway, anything that's going to cause lung issues can lead to this condition. Increasingly, we're seeing this obesity hypoventilation syndrome, and the weight of the chest in an obese patient is too much, and there's too much effort required in order to raise the chest just with inspiratory muscles. So they end up developing pulmonary hypertension, and then can lead to a condition of cor pulmonale, obstructive sleep apnea, and a number of other things. So that, as you encounter higher and higher pressures, again, the similar phenomenon as congenital happens here. You get increased PA pressure, you get hypertrophy, you get dilatation, and ultimately you can get systolic failure. And that's a condition. You can have acute cor pulmonale or chronic cor pulmonale, or acute on chronic. And this is difficult because you really have to treat the underlying condition. What has caused this patient to develop the condition? Because there's not a lot of help for the secondary condition of cor pulmonale. So you have to deal with all these things. The acute PE, obviously, we may, if you have a lot of RV strain and dilatation, sometimes we use thrombolytics or fibrinolytic therapy to relieve that resistance to flow. Otherwise, patients at high risk in the acute state. Chronic PEs can ultimately lead to this, and just in better treatment of lung disease, or actually recognizing, diagnosing sleep apnea, and beginning to treat that can cause an improvement in RV function, as well as, in that case, actually LV function as well. So, that's that. I missed a couple things on categories. Well, we have, I'll get to those. I'll just list them here. There's the high output state. There's also the tachycardia mediated. And there's the toxins. So for the hypertensive, this is not something where, a minor league hypertension, a 140s or systolic 150s is usually going to lead to a state of heart failure. But, if they have persistent, usually moderately to severely elevated blood pressure over years, they can lead to remodeling, hypertrophy, and certainly diastolic dysfunction, which is an impairment of relaxation of the myocardium between the systolic phases, while the heart's trying to fill up the blood between beats. They can develop this problem of failure to relax because the heart muscle has become so stiff. And we'll circle back around on that whenever we get to the heart failure side of things. Still, we're not even in the clinical syndrome yet. We're still just in the cardiomyopathy side of things. So high output syndrome, less common, but you can see this. So in a state of high output would be a number of things. You can get this from shunts. So a condition where they have a lot of AVMs. Sometimes in the dialysis patient, if the fistula is too high output, that can cause a problem. It's not restrictive enough, and they just end up having not enough resistance, so the forward flow is tremendous, and the heart cannot keep up with the cardiac output of 7, 8, 9, 10 liters per minute. So that's why we have to kind of modify these as we can. The other high output states would be things like less commonly hypovolemia. If the patient has bled and they're dealing with not much intravascular volume, they may be trying like heck to keep up with the low volume state, and they're pumping very hard to get that out. It's not for any other reason than the heart's being overworked that they develop an abnormality of the heart muscle. There are also other things like thyrotoxicosis, so a high output state because the thyroid is overactive. Less commonly a pheochromocytoma, and again a few other zebras out there that can cause a high output state. If they have persistent sepsis to, again, a high output state that can lead to usually systolic dysfunction. If you get to these folks, and this is the case with most of these things, if you can get to make the diagnosis and begin to reverse the underlying condition earlier in the disease course, you're more likely to have recovery of myocardium. If you let it go and let it go, you're going to end up developing clinical syndrome, and it's much less likely that you're going to reverse the cardiomyopathy. Not impossible, but your chances go down. A bit about tachycardia-mediated cardiomyopathy. These are folks that have a tremendous burden of higher heart rates. Again, sometimes these can be it can be from a number of things, but most commonly we're talking about atrial fibrillation, atrial flutter. Less commonly the supraventricular tachycardias, but they like the AVNRTs, the AVRTs, atrial tachycardia. There is also a concern when a PVC burden, not necessarily PACs. If you have normal conduction from the top to the bottom of the heart, as a PAC does, the PAC is an early beat. If it conducts in that manner, you usually don't get ventricular cardiomyopathies. If you have a PVC burden above 30% of all complexes, we think that may actually be a contributing factor that can lead to low pump function, because you're changing the direction of electricity. Again, as long as it's going in the right direction, even if it's fast, the heart tolerates it much better. If you start to generate an irritable focus down here, you're constantly causing this mistimed myocardial contraction that's out of sync from left to right or from whatever direction it's coming. That's where, at a high frequency, you can get something like, this is a kind of a cousin to the tachycardia-mediated cardiomyopathies. Again, fixing the underlying arrhythmia is how you treat the condition, although in the meantime you can use the evidence-based medical therapies to help you to recover heart function. Toxins. Depends where you live, what's going to be the more common toxin. For us here, alcohol is by far the most common toxin leading to cardiomyopathy. And, we've kind of modified what we think is a safe dose. And this is variable. What we say on average, that usually more than 2 drinks in a man, more than 1 drink in a woman, chronically over time is a problem. As much as 10 grams of alcohol is thought to be could cause a cardiomyopathy, and that's, again, you have to sort of out calculate how much somebody's drinking per drink and per night to figure out a 10-gram dose. But that's more trivia than actual practical knowledge. So alcoholic cardiomyopathy can be very difficult. The patients are oftentimes not as forthcoming with how much they're drinking, and they have a big problem in quitting. So we have this issue of constantly counseling them, and they think that any particular, even if they cut down, that's okay. That's better than high dose, but still, any level of toxin at that point, once there's been damage, is really a bad idea for these patients. If they quit drinking, sometimes they can have spontaneous recovery, other times not. we always use our evidence-based medical therapies in order to help them recover their myocardial function. If that doesn't work now, I mean, I have patients in my panel now that were alcoholics, 5 years ago, 10 years ago even, and they stopped. I believe that they're not drinking anymore. There was too much damage over a period of time. Like I said before, we didn't catch it early enough. There's enough fibrosis inside the myocardium that it's not going to get better. Other places, and to some extent here, cocaine is probably the number 2 toxin, and that has to do with the direct poisoning of the myocardium usually from adrenaline, as well as just the physiological demands placed on the heart from use of that drug. I keep thinking of new categories. There are other toxins too, but just in the interest of moving through the topic here. Stress induced. Okay, so this goes by a lot of names. Takotsubo cardiomyopathy is the typical name that we give it. And so you'll probably know what is the Takotsubo? How did it get its name? It wasn't Dr. Takotsubo.
Octopus or something.
Yeah, the shape of the
So Japanese fishermen hunting for the octopus will put this pot down on the bottom of the ocean floor, and something like this. They put a little bait in here. The octopus swims along. They can, they don't have a skeleton. They can squish their head to get through the neck of the bottle to get the bait. But then how their propulsion system works is they have to swell up in order to expel water, and they can't back out of this. So this pot is called a takotsubo. And as it turns out, the shape of this looks a lot like, on a ventriculogram or on an echo, it looks like the shape of the heart of the left ventricle. The reason that happens is if this is the normal configuration, what we end up getting is hypercontractility and ballooning, hypercontractility of the base. And we get ballooning of the apex. Why does that happen? Well, as it turns out, there are a lot more adrenaline receptors on the apex of the heart. And when you get an excess of adrenaline, it overstimulates the myocardium, and kind of it's similar to an ischemic state. When you have an acute occlusion of the coronary artery, you can get hibernating myocardium. That's because there's a program in the myocardium that says, when there's trouble, shut down. You've got to wait until the coast is clear, and then when it is, when everything's better, you get back to working. Same thing is happening here. You get poisoning of the myocardium from too much stimulation from adrenaline. It shuts down in sort of a hibernating program. It can begin to dilate because of the internal pressures pushing it outward. But there are fewer adrenaline receptors, such that you're going to get all that adrenaline excess, increased inotropy and chronotropy. All of that's going to happen on the base of the heart, and so you get this really thin-necked left ventricle that can sometimes cause an outflow obstruction. Not commonly, but it can do this. But you set up this configuration. The problem with diagnosis is that this looks a lot like some LAD territory infarcts. So we have to take these folks to the cath lab. We have to rule out any LAD obstruction, and then we can we get into their history, and then we find out that they've had a traumatic event or something else that's caused an excess of I've had this happen with oh, and by the way, the female predominance is much, much higher and also postmenopausal tends to be somewhat higher, but mainly the main factor is female tends to be the big predictor. I've had males with this too. And by the way, just to dispel the myth, it's not because women are more emotional. It's not that. Actually, women have more adrenaline receptors on the apex, so they're more sensitive to the effect of the excess adrenaline. So we treat this in the usual way of trying to, one, recognize what caused the stressful condition and help them to get whatever social support they need to overcome that. I mean, I've had this from death of a spouse, death of a pet.
Colonoscopy.
Well, on occasion, yeah, you'll get things where people are freaked out about any particular thing, whatever it is.
But then it got deeper. She had
Yeah.
polyps the first time she had a colonoscopy. She was afraid she'd have more.
Right.
It's interesting. I had 2 this week.
I just heard
I've had women
Two
in
times
abuse
this week.
get this. Now, here's the other thing. I've also gotten it from sort of a non-emotional stress type of patient. Patients with COPD, if they're blasting with albuterol, what is that?
Yeah.
It's essentially inhaled adrenaline, and it can have that effect. Theophylline also really upregulates these signals. And again, the lung patient can develop this kind of cardiomyopathy through the same pathophysiology, but a totally different stimulus. So these are the, and I've probably missed some, but these are the major categories of cardiomyopathy. Any questions about this before I wipe it?
What's VHD?
Valvular heart disease.
Oh, okay.
Yeah, some of these were not primary cardiomyopathies. These are secondary conditions where you have another underlying condition like valves or congenital abnormality or something else that's led you to develop cardiomyopathy. There's other things. There's other metabolic type things that I didn't put on here. But that would be the best example is diabetes. So the high glucose state leads to essentially a cross-linking of the myocardial fibrils with these glucose particles, and when you cross-link, and it'll lead to fibrosis and poor function, and usually the diabetic will have diastolic heart failure manifestation, and of course they're at higher risk for ischemic and other things, but diabetes is the biggest one that we see for them. Okay. This is where I hope I haven't drawn a permanent marker.
Like I can't write anymore.
Okay, so heart failure. We just, again, as we got started this morning, we were talking about sort of the definition of terms. Cardiomyopathy is not the same thing as heart failure. Cardiomyopathy, we just went through all these things that cause either a structural or a functional abnormality of the myocardium, but it's not necessarily a clinical syndrome. Patients can be completely asymptomatic with a cardiomyopathy, or they can go on to have heart failure. But now we can talk about heart failure. So what does this mean? Does this just mean that somebody's short of breath and swollen? Actually, that's not enough to make the diagnosis. And so you have to think in your mind, what was the basis for the heart failure diagnosis for all of the clinical trials that led to all the medical therapies that we use for heart failure patients now, right? So this is something that is taught in all nursing and medical schools, that unless you have a set of patients that are somewhat similar to the studies that form the basis of medical therapy, then you don't know if they're actually going to respond the same. So, what is heart failure? Rather than write this all down, I'll just kind of tell you. The general working definition that I use, the simpler thing is, it's insufficient cardiac output to meet the metabolic demand of end tissues, end organ tissues. And that's insufficient output that that can come from either a low pump function or an inability to relax and fill the ventricles in order to generate effective output. And that manifests in some clinical syndrome. And the clinical syndrome is really the key to this. So yes, you have a heart that's not meeting the metabolic demand of tissues, but the syndrome is really what we're after, because that's the nature of heart failure. I would suggest to you that probably the most commonly accepted definition of heart failure is the Framingham criteria. Have you all ever heard of this? I'm just not sure how much it's taught. So for Framingham criteria, you either have to have two major criteria or one major. Gotta have my coffee, or any coffee. Minor. Two major criteria or one major and two minor criteria in order to make the Framingham diagnosis of heart failure. So it's a sensitive tool in order to diagnose heart failure. It's about 97% sensitive. Specificity is a little bit poor. 79% specific. So it doesn't necessarily rule in the patient, but it can rule them out. If you have a patient who's swollen and short of breath and you go through all this and they don't make the criteria, only 3 out of 100 times do they actually have heart failure. 97% of the time, if they don't meet these criteria, they probably don't have heart failure. They may have something else. And that's why it can't just be the swollen ankles that makes the diagnosis. We really have to get into what's causing this. I mean, there's venous insufficiency, there's nephrotic syndrome, there's liver cirrhosis, there's so many other things that can lead to other symptoms that are somewhat related but not exactly heart failure. Okay, so I'm going to list categories here, major and minor. And have you tell me what you think might be some criteria for heart failure.
Left ventricular systolic dysfunction.
It's actually not on there. More of a clinical diagnosis. What are the other things that you're going to encounter? Some of these, before you get to echo.
Okay. Symptoms.
Yeah, symptoms or signs on exam.
Hitting edema.
Oh, JVD.
The edema's over here. And you have to think of it this way. The minor criteria are going to be less specific. So it takes more of these, less specific things to help make the diagnosis. The more specific things are going to be on major. So you said JVD?
JVD.
JVD is a major.
Or apnea.
It's not on there.
Okay.
Probably should be, but it's not on the formal Framingham criteria.
PND.
Yes, PND. And I have to tell you that paroxysmal nocturnal dyspnea, in my experience, is probably the most specific. It's not the most sensitive, but if they have this, there's pretty much you can stop.
Really?
PND is the most specific that I've found for the diagnosis.
That's crazy because many patients ever say that.
You have to dig a little bit,
Really?
and it depends how you ask the question.
Oh.
So, I will often ask them if there's ever been a time when they've woken up in the middle of the night feeling smothered and they have to sit up to catch their breath. That smothering sensation is sort of the key word that everybody can relate to if they have this condition. Smothering and having to sit up, drowning, these sorts of things, and then they sit up. And sometimes they'll attribute it to a panic attack.
Right.
And then they feel better when they sit up. Not in the orthopney case, because that's they're conscious and they lay down and that doesn't feel right. I need to. This is more of a middle of the night type of phenomenon.
So if they already have sleep apnea, because a lot of them will say, well, yeah, but I have sleep apnea, then I got that treated and I'm better.
Right.
So is that
it's a little bit
that
difficult to
relevant?
parse at that point. It's
Okay.
that may well have been apnea that they wake from.
Okay.
But honestly, most apneas from sleep apnea
Don't actually
don't wake
wake up.
actually. So it may well have been PND that gets better.
Right.
And you're treating the acute heart failure. because you're treating the underlying condition that led to it. We'll get to why these things. Why? Well, actually, let me just talk about it briefly. The P&D can happen. Why? Because you're not getting an immediate orthoptic response, but in fact you're getting a condition where the patient's been upright during the day. Gravity's pulled all the fluid to the lowest place in the body, and that's when we get the more impressive lower extremity swelling, or maybe abdominal bloating. But when they lay down, they may not immediately feel that sensation of drowning or smothering. But it's when the gravity then is no longer pulling fluid away from the chest, it'll settle back up on the chest. And then it's in the middle of the night, they're feeling drowning, because they are. And then they'll sit up and gravity then will push it back down, and that's why it relieves them. So that is very, very specific for heart failure. A quick note about JVD. Every single heart failure patient that I see, I'm marking in the physical exam portion what their JVD is. Now, you want to make some kind of objective measure about what's happening, and so you have to say about whether the patient is upright, or essentially either not standing so much as if they're sitting in a wheelchair, and it would be a huge ordeal to put them on the table. I just don't. But you can tell. You go and look at the neck veins, and I use the reference of the clavicle. And I'll put on the note that I have jugular venous pressure at the clavicle. I can see the bounding right there, which is elevated, by the way. If you have JVP at the clavicle sitting upright, you're already into about the 15 millimeter range, or 15 centimeter range of water pressure. If you have, and then after that, I don't get very technical about, how many centimeters from the right atrium is it? And there's some people that try to do this. I think that's too confusing to the next person who reads your note. But what's very clear is that you can say, I see JVP 2 centimeters above the clavicle sitting upright. I see it at the mid-neck. I see it at the angle of the mandible sitting upright. Or if they can at all lay down, I try to get them at about 30 degrees. And then what that does is it lowers the threshold for detecting elevated JVP. So at this point, I mentioned that this is about 15 centimeters water. This is about 5 centimeters water if they have JVP at the clavicle at 30 degrees. But again, you don't get too technical about it. And then I just make the same comments about JVP at mid-neck at about 30 degrees. It's objective and it's reproducible, not only by you, because you can immediately put the patient back in the same position and compare what they're doing now to what they were doing before. Then your colleagues can do the same thing, and it takes a little bit of skill and time to begin to recognize this well. But this I highly encourage. Some objective, not just JVD plus, because that's usually what we write. It's just, yes, they have JVD, but it's a quite different thing to have JVD up here as opposed to just a little bit above the clavicle. Okay, that's that. What are some other criteria?
Is it just as positive if you have to push on the liver to get it to
What's that
really
called?
show up?
Just for hepatic reflux?
Yeah, hepatojugular reflux.
Yes. Oh, so that's a whole other
Something.
symptom.
Yeah, hepatojugular reflux is another major criteria,
You
and
check that on your patient?
it's based on this same concept that yes, you may not be in a decompensated state, but if you can push on the liver, that means the liver already has potential space for congestion from prior heart failure exacerbation. If you push on there, it pushes. So you have the liver, you have the IVC, you have the heart sitting here, and then you have the SVC, clavicle, and then the jugular veins. So when you push on the liver, this pushes the blood column up the IVC, through the right atrium, through the SVC, and then that's when you can put, if the pulsation's right here below the clavicle and you don't see it on exam, you push here, that may be enough to increase your sensitivity. So this is again, something that's very specific that allows you to increase sensitivity of the overall tool. What else?
Rails.
Rails is major. Anything else? Some of the other common things, dyspnea, exertion.
Weight gain, early satiety, fatigue, abdominal fullness. I don't know how many of those
Yeah.
things are on there though.
None of them, but these are all actual symptoms. These are symptoms, but you can imagine, weight gain is too
Vague.
non-specific
Yeah.
and attributed to so many other things that it doesn't make this list, but it absolutely
Makes
in-
our list.
in the context of things. Yeah, we're asking it, and it matters. Some other things are S3 is very specific. Over here. So there's going to be a hepatomegaly. And other things can cause this, but if you have it over here, that's one of the minor criteria. Heart rate greater than 120 in sinus rhythm. Now, if you have AFib, that doesn't mean automatically that's a minor criterion, but it's in sinus rhythm. This is an adaptive physiological response to a low output syndrome, or to a congested state that'll lead you to have higher heart rates. And
What about like abdominal ascites, or would you think more liver first?
Ascites doesn't make the formal list, but again, it's one of those things that absolutely we're thinking about and asking for. So, yeah, just talking about the formal list. The other thing that depending on the list, is considered either major or minor criteria, is that if you have a 4.5 kilogram weight loss over 5 days due to diuretic therapy. There's, if it's nephrotic syndrome and if it's cirrhosis and other things, you don't tend to lose this much water unless you're tapping the patient or dialyzing the patient or something else. But that also
This is with diuretic.
diuretic. Yeah, this isn't tapping. Because yeah, you could do a paracentesis and get 5 liters. Okay, and there are other things. There's radiographic cardiomegaly, and there's other stuff on here, but these are the major ones that you'll encounter. So 2 of these that are very specific, or 1 of these and 2 of those, is how you rule out potentially a heart failure diagnosis. But it can also help you to clinch the diagnosis.
So you wouldn't even suggest ordering an echo without these criteria being met first?
Well, it helps you in the decision making.
Okay.
If you're going through these and you say, well, the patient has swollen legs and they've been referred for evaluation of heart failure, because if the patient's ill and they have a heart, it's got to be the heart swollen. So, you can begin to think, well, yeah, you do have edema. This is just meant to organize your thoughts about what other things that you can think about. And if you have a couple of these, again, the sensitivity, or the specificity is 79%. Yeah, you probably have it, but then you go on for other confirmatory testing. But if you try to go through this and, despite your best efforts, you cannot make 2 majors or 1 major and 2 minor. Again, only 3 out of 100 are actually going to have heart failure if you can't make this list. Can't make the criteria. Okay, questions about that? Is this helpful? Is this what you guys want?
Very, yes.
At what point do you want us to send them to you?
Well, I'm happy to provide second opinion on heart failure, complex heart failure management. I'm happy to co-manage, or I'm happy to assume care of a complex patient. So it can be a once and done, or the periodic, or just take over kind of setup. And I really leave that to others. It's not so much about what I want to see in the clinic. It's how can I best help the practice and help the cardiology community. But we do have, and we can kind of get into what specific offerings we want to have down in the heart failure clinic that are a little bit different. Because there's another, just general. Let me get into the demographic or the disease prevalence here just a bit. This will be quick. But I can tell you that in 2012, there were about 6 million patients in the U.S. with heart failure. And it costs about $30 billion to take care of them. It's crazy. And if you think about it this way, I mean, how much have you heard about healthcare reform and how the healthcare system is strapped? We can't pay for the patients we have now. And why does heart failure come into the crosshairs so much? But it's the number one most prevalent diagnosis in Medicare age patients. It's also the costliest, and it's the number one cause for readmission. 80% of the cost of caring for heart failure is in the hospital. Now it's real clear why heart failure is in the crosshairs. If we're already in a strapped healthcare economic scenario, and then you've got all these factors here affecting the bottom line, of course we're concerned about the disease burden and the patient struggle, but we just can't afford to take care of things if we use traditional techniques and tools with the idea that this is going to get worse. Look what happens next. In 2030, which isn't, it sounds far off, but it's a dozen years away. This is what's going to happen. We're going to go to over 8 million patients with heart failure, and that's a significant increase. And why is that happening? But we have 10,000 Medicare enrollees every day. It's hard to imagine there's that many, but these are a lot of the baby boomers that are adding to the rolls. We're less physically active. There's more diabetes, more obesity, and hypertension, coronary disease, and everything else that drives heart failure is also increased to some extent. There's some exceptions to that. And as we get better at treating ischemic heart disease, you have more survivors of MIs and of valves and other things that then go on to struggle more long-term with heart failure. So the disease burden goes up. Now, if this was $30 billion, this goes to, I believe, the number of $70 billion. So you get a 2 million patient increase, but look, you get more than a doubling of the cost of care delivery. So a huge problem that's going to get impossible to take care of unless we begin to develop new tools and techniques. That's going to be medical therapies, device therapies, and more than that, it's going to be systems of healthcare delivery that help us to better care for this huge burden of patient disease. And that's, that could be a number of things. There's a lot of the pipeline for drug development, at least the old numbers, where that it takes 15 to 20 years. This is from the bench concept in the molecular lab or the biochemistry lab. It's 10 to 15 years and between $4 and $12 billion to develop one drug that makes it to FDA approval. We don't have the luxury. Now, there's a lot of things in the pipeline that have been going on for decades, but that's huge. And there's no wonder the cost of medications is so high. I don't know what the pipeline or the expenses for devices. It's less, but it's tremendous. So, we can't wait and rely just on this. We have to think of these new healthcare delivery models. We have to think about how we can reach out to the patient where they live. Especially, our scenario here is really a good example of a spread out population. Hub and spoke model is more helpful to reach into the communities, and we also have things like telemonitoring, and this is going to be a big part of how we do this in the future. I probably won't have time to talk about this today, but there's the CardioMEMS that just met or was added to the new criteria or the new guidelines. You all know that a couple weeks ago we had new comprehensive heart failure guidelines that came out. We replaced the ACC/HA HFSA guidelines from 2013. It happened the day before I went on vacation, and honestly, I haven't had time. And then I've been on call and other things. I'm going to come up with sort of a digest of all the big major changes that have happened, but CardioMEMS is one of the things that's included on there. And as you all probably know, this is a sensor that gets placed by right heart catheterization in the left lung, pulmonary artery, and then it's so it sits over here in the left PA, which, by the way, is very close to the heart. And this senses, the main thing that it senses is PA pressures. And we get daily measurements of what's essentially ICU level hemodynamics that comes back to our monitoring system remotely. And we can begin to detect elevations in pulmonary artery pressure that can precipitate clinical worsening of the condition by up to 2 weeks. So the idea is if you don't respond to the single elevated pressure because most of these normalize, but if you have a trend of worsening data, then you can call the patient, say, how you doing? I feel fine. And then you can adjust their medications before they even have to struggle with symptoms. And that's what's led to a 46% reduction in hospitalization. That was the case in the Champion trial that was published in like 2010 or so, 2009, 2010. Took a while to finally get it out to commercial release, but there was a real world study that was just published recently that shows at least as good of real world clinical outcomes as there was in the trial, which is rare. A lot of times we contort these clinical trials to give us the best possible scenario, and the real world actually turns out to be just as good for this particular technology. Now the challenge is it's terribly expensive. Medicare surprisingly pays well for it. Private insurance pays relatively poorly for it. And so getting prior authorization is sometimes challenging. You're also limited if the patient is of a certain obesity level or if they have a certain chest girth. The idea is that they lay, they're laying down on a pad, and if the pad is too far away from the sensor that's sitting here, you won't get a good signal. This is not for a non-compliant patient, because if they're going to exacerbate and not do what you tell them anyway, they're not going to do what you tell them in the office or over the phone. Mm-hmm. So this doesn't fix compliance. Unless you have a patient that they need to feel like they're being watched and supported. Mm-hmm. And I've had some of these where you put it in and they were trying to do the right thing, but their constitution, they were a little bit weak in their ability to resist temptation. Mm-hmm. But when they knew somebody was watching, they wouldn't need the hot dogs and all the things. So that's been a nice advancement. But when I talk about the overall disease burden of things, this is just one example of how we need to think outside the box in a different way in order to monitor patients to prevent what accounts for 80% of the cost of healthcare delivery for heart failure, and that's in the hospital. That's why the hospitals get so bent out of shape about readmissions. Well, that's because the government's bent out of shape about readmissions, because the government is the biggest healthcare insurer anywhere. Between Medicare, Medicaid, and the VA, that accounts for most of the healthcare in the U.S., at least for the patients that we deal with. So we have to think about other things too, and there's going to be less invasive things that'll probably come down the road that don't require right heart cath. Because anything that requires subspecialty experience and certification and so expensive, it's going to limit the scope of how widely you can apply the technology. So as you begin to get things that are less invasive, less expensive, that can be put in non-cath lab environments, then potentially you're going to be able to use this in more patients and affect more of the bottom line of this. And then not just implantables, but wearables are also going to be possible. And there's already commercially available wearables out there that are thought to potentially predict heart failure worsening. We did trial one of those, and it has an FDA label right now, but that's so I can talk a bit about it. It's the Smile or the Sensible Medical vest. It's a vest that they would put on each morning, and it would detect the thoracic fluid content of the chest. So it's just one example of many new technologies coming down that we hope will help us to predict heart failure in the future. But especially if you can detect it even before the patient has symptoms, the better.